This webinar will demonstrate the capabilities of icobrain MS, and some clinical case studies will be presented by Professor Nagels from the University Hospital of Brussels. He's a neurologist, but also has a degree as an engineer and is an MS expert worldwide. So I also need to mention he's a minority stakeholder of icometrix. So first introducing to you icobrain MS, or cloud software for the processing of brain MRI scans applied for multiple sclerosis. In multiple sclerosis, we know from literature that almost 26% of the patients starts on a treatment that gives a suboptimal treatment response. And to decrease that number, it is important to use tools that can early predict disability progression, that can predict the relapses, and can predict treatment response. And as such, we can reduce that time and, simply put, we can give the right treatment to the right patient at the right time. So for that, we have developed a software called icobrain MS, and it gives an overview of the most important outputs of our software. So in the middle, you see our quantitative reports, and they will also be the central part of the cases that we will discuss. So it was a 2-page report with on the first page information on the lesions, and on the second page, the information on the brain atrophy. On the left, you see also that we provide back annotated images where the segmentations are color-coded. So we give back segmentations of the lesions. Here you see an example where the color coding indicates the location of the lesion inside the brain. And on the right side, that's our third output of our software is a natural language report, which is provided back in a DICOM structured report format, which is a tool for the radiologist helping to read the case faster and more consistently, because this is a pre-written radiological report that can be used to start from when doing the radiological reading. But today we will focus on the clinical side of the use of icobrain MS, and I want to shortly touch upon the recent guidelines that have been published. So on the left of the slide, you see, let's say, the most conservative guideline, which is the guideline published by the American Association of Neurology. In the middle, you see the guideline published by the European Association of Neurology together with ECTRIMS, which is the MS Society in Europe. They jointly published guidelines that correspond very well with the NIDA-3 criteria. And on the right side, the most progressive guidelines are the brain health recommendations, which are set together by a group of key opinion leaders in multiple sclerosis, led by Professor Giovannoni of Bart's Hospital in London. And these recommendations correspond to the NIDA-4 criteria. And just shortly recapitulating the NIDA criteria, so there a treatment is assessed to be working well if there is no evidence of disease activity. In NIDA-3, this means there is no evidence of disease activity according to 3 axes. There are no relapses, there is no increase of EDSS, and there is no MRI activity in the sense there are no new flare lesions or T2 lesions. And in NIDA-4, there is also a normal brain atrophy as an additional criterion to define that the patient is on the right treatment. Applying these NIDA-4 criteria very strictly could reduce the amount, the time on the suboptimal treatment theoretically with 32 months. Today we know that on average patients are for 47 months, so that's almost 4 years on a suboptimal treatment. By applying more progressive treatment guidelines and having, as such, earlier switches of treatment, this could be reduced to 15 months, according to the publications mentioned below. So that ends a bit the first part of the webinar, where I shortly introduced icobrain MS and its potential clinical value. We will now continue with some case studies that will be presented by Professor Nagels of the University Hospital of Brussels.
Good afternoon, or good morning, depending on your location. So we've prepared a few cases for you this afternoon, and we think that they illustrate some different ways in which quantification of MRI imaging could help us in clinical practice. And the first case study is a man born in 1972. And as you can see on the top part of the screen, this is data listing the therapies that this person was on, which was mainly Copaxone. And here you see the neurological episodes or relapses that this patient suffered. And here you see the EDSS scoring. In this patient, we could argue that this is quite a high frequency, and perhaps not all of these clinical events would fully meet the criteria for a full-blown relapse. But still, this gives an indication of the new complaints that the patient presented with. The red line means that the MRI that we're going to look at was taken at about this time. You also see that the patient had been treated with Tysabri, but had to be taken off again because of a poor tolerance, which is why he was again placed on Copaxone. And here you see the example of an icobrain MS report for that patient. With a comparison of the MRI of 2012 versus 2011. And if we look at the right side of the screen, you see a sagittal image that shows changes in lesion volume. I've lost my pointer, unfortunately, but you see that there is a green area on the screen to the right. And that is the lesion volume on this slice of the brain that was already present in the first scan. And then a small red spot that shows the lesion that is new on this image. And then the yellow-orange spots, those indicate, as Dirk explained, the extension of the lesion that was seen on the previous scan. So I think that in my practice, this helps me to discuss MRI results with patients because they are most of the time not used to looking at images. And with this color coding, that explains the changes to them in a more accessible way. When we look at the left side of the figure, you have the one of the tables in the report. And this shows that the volume of the flare hyperintensities is a bit above 7 milliliters. And the volume change between those two MRIs was close to 1 milliliter, which we could consider to be a relatively large increase, relatively speaking, compared to the total lesion volume. You can also see on this image here, the yellow spots do not mean an increase of lesions, but on the left side of the figure, this means that the lesion is periventricular, or the software proposes that these lesions are periventricular, and you see other color coding for other types of lesions, which can also increase the visibility of the lesions for yourself or for patients when you discuss them with them. So here we have a patient who has an increase of lesion volume, which is relatively speaking large. And if we look at the following, the continuation of the clinical story of this patient, then we saw that the EDSS worsened. There were also new clinical complaints, and this led to a change in therapy, and we were in 2013 then. Since the patient had, since Tysabri was no longer an option, at that point in time in Belgium, Gilenya was, according to our feelings at the time, a good choice for this patient. So the EDSS kept worsening. Apart from the MRI information that we just discussed, of course, it's also important to discuss therapies with our patients. And this patient was then later on reluctant to switch to yet another disease-modifying drug. Currently he is still on Gilenya. The second case study that we wanted to show is a woman born in 1968. And here you see her clinical evolution with an MS onset in 2011, and then some clinical relapses. And then the patient only started on Tecfidera in 2015. This patient was reluctant to start injectable therapies before that, but was willing to start oral therapy at that point in time. EDSS was relatively low, as you see on the bottom of the figure, with a score of 1. And when we look at the quantification of the MRI results, we can see that there is a relatively pronounced brain atrophy. If we look at the left figure, then you see a volume measurement on the y-axis, and on the x-axis you see time, and the time is the age of the patient in years. And so you see that the two crosses for this patient, for these two measurements, are in the dark blue zone, which is the zone below the first percentile of a normal control group. So that is a quite pronounced brain atrophy, and the brain volume is decreasing further when we compare the two measurements. The gray matter volume was relatively preserved with measurements between the 10th and the 50th percentile. I think most neurologists feel that atrophy could be a good predictor of future disability, and this is also a reason why I think many neurologists like to add it to the NIDA criteria as a sort of marker of neuronal damage in MS. And I think most neurologists also feel that if the brain volume gets low, that the reserve for displaying clinically significant symptoms is also decreasing. So in spite of the relatively good EDSS evolution in this patient, this observation does not seem so good. And unfortunately, if we look at a further clinical progression of the patient, we see that there indeed is a progression, and that the EDSS has been increasing in this patient. So the medication was continued. If we look at NIDA 4 criteria, as discussed in the first part of the webinar, we could have considered a treatment change. Of course, apart from the MRI measurements that we do, we also have to discuss things with our patients, see if they are willing to switch. And we also have to take into account reimbursement criteria to see if we can indeed do a switch in certain circumstances. So this was a second example. The first example was an illustration of how we could use data on lesion volume. This is more an illustration of how we could use atrophy data. And then we move to the third patient case. And this is a patient who was, at the time of the MRI, 43 years of age. And at that point in time, he had recently switched to Tysabri because he had continued to have relapses on interferon, and also already had a relatively high EDSS of 5. When we look at the MRI analysis at that point in time, there is also a marked low brain volume. When we look at the left figure again, with the volume in the y-axis and the age in the x-axis, we can see that the measurements are below the first percentile. One caveat is that the follow-up period in this case is relatively short, so that can increase the uncertainty on the measurements. But still, this looks like an abnormal atrophy compared to normal controls. Also, for the gray matter volume, this patient is at the lower edge of the scale at the first percentile compared to a normal control group. And when we look at the further evolution of this patient, he initially continued with an EDSS around 5, but then further increased in EDSS. The patient was continued on Tysabri. As you know, EDSS 6 is not very sensitive to change, and the clinical feeling was that the patient was still losing function, but he still had a lot of function to protect. He was still working, which was relatively unusual because he had a job as a computer software designer, which was relatively cognitively intensive. But he was able, with some adjustments of his workplace, to continue working, which was also a reason why we felt it was necessary to continue on Tysabri, even though this patient had a relatively high titer of anti-JC antibodies. Unfortunately, this patient then developed a PML, which is, of course, a bit out of the scope of discussing icobrain software. But here you see that he developed PML with an increase in disability. And unfortunately, he is now at a disability level of 9 after this PML. When we continue to look at the period before his PML, which was about here at the age of 48, we can see that the measurements of the atrophy were continuing to decrease. And this was quite worrisome because the patient was still active. So we felt we had to do everything we could to protect him with means that were at our disposal at the time, while we still saw that the atrophy was increasing. And then we come to the fourth and last case study that we lined up for you tonight. And this is a young woman who was close to 40 at the time of the first measurement. And this measurement compares 2015 versus 2014. And we see here that the brain atrophy seems to follow the lines of the normal controls. You can look at this a bit like you would look at a growth curve with the percentiles. And the last measurements seem to be following not a growth curve, but a percentile line, while the initial decrease in volume seemed to be more pronounced. And here you see that for the gray matter volume measured separately, that the patient also sort of slightly dropped beneath the 10th percentile. And when we look at the numbers, when we compare 2011 and 12 and 2012 and 13, we can see that there is a volume change of about 1% annualized. Here also 0.8 annualized, which is more than we would expect in normal controls. And comparing further 2013 to 14 and 2014 to 2015, we see that the decrease in brain volume is lower in these time periods. So there we have an effect that it seems like in the beginning of the monitoring there was a more pronounced atrophy effect, which was then later decreased. And here you see the clinical elements in this case. So an MS onset in 2001, and then quite a long period of time before a second relapse, a very long period of time. Although we did, my apologies, I think something is missing here, because we did briefly try Rebif as an injectable drug around 2010, which was not well supported. And then the patient elected not to have other injectable therapy, but she was willing to start on Tecfidera when this became available in 2015 in Belgium. Unfortunately, she, because of her relapse activity, she moved from a relatively low EDSS to a more pronounced EDSS level, which now seems to be clinically stable, and she continues to be under Tecfidera. She has, as the EDSS suggests, clear gait difficulties, but still has a very active lifestyle, taking trips abroad and having an active career. Okay, so those were the 4 cases that we lined up for you tonight. I'm going to give the microphone back to Dirk.
Thank you, Professor Nagels. Thank you for this nice explanation of the different cases. We would also like to invite you to subscribe to the newsletter of icometrix just by browsing to our website, icometrix.com. Thank you so much.